Okay, so I think we'll go ahead and get started. So welcome everyone, and thank you for joining our session today. Today we're going to be talking about understanding the diversity of different patient-reported outcome implementations across the healthcare system to really facilitate an enterprise approach to PROS data use. My name is Elizabeth Austin. I am from the University of Washington, as well as the other members of my group here. And as the moderator, I wanted to take just a couple minutes to set some background and framing for how we came about this work before I let the panelists launch into what they have to say today. So just first to acknowledge AHRQ and CMMI for their support in this work. At the University of Washington healthcare system, we have 4 hospitals, the Seattle Cancer Care Alliance, and a network of specialty and primary care clinics. And those institutions are represented by the rectangular boxes here. And although our team has been working in PROS for many years, even just 3 years ago when we looked at who within our healthcare system was utilizing PROS in the clinical space, we found that the use was pretty limited. And so these were the examples of the use cases that we saw 3 years ago. But when you fast forward to today, the use of PROS has grown quite exponentially, and that's really been driven by some organic increases by clinical teams who've identified the value in having patient-reported data included in their clinical decision-making processes, as well as from value-based payments that have an element of patient-reported outcomes as part of the quality reporting that we need to be able to report on. So as we started to organize our system around patient-reported outcomes, we underwent a process of cataloging some of the existing implementations to try and understand what was happening. And so this is some of the things that we found when we cataloged some of the examples of implementations. And some things that stood out to us as a healthcare system right away are that there is an opportunity to really do a better job of integrating this data into the EMR meaningfully so that it can be used for clinical decision-making. But also that many of these PRO domains are shared. So a lot of the general measures that are just numerically represented here, there were a lot of shared domains that people were measuring, but measuring in different ways. So there was a significant opportunity for us to align how we were measuring PRO domains across things that multiple stakeholders were interested in measuring. But more importantly, this cataloging process allowed us to really develop some case studies for different models of using PRO data in clinical care. And so this diagram presents 3 of those models, and these are the 3 case studies that we'll dig into today. But for example, in the primary care space, PROs might be used as a more comprehensive annual screening, and then in follow-up appointments in between those annual screening time points, more limited use on only the items that are of risk or of interest. And headache management, which is more of a chronic disease focus, it is really critical to have PROs measured at every single time point so that you can really track interventions over time. And then in the surgical space, you may have pre-specified time points for when you want to follow up on PRO measures to support population health, but those time points may or may not relate to when the patient's actually coming into the clinic and seeking care. So all of these different use cases have impacts for how we want to think about the system approach to measuring patient-reported outcomes. So this process of cataloging the PRO implementations and developing case studies will really help us as we move forward in the next phase of our work, which is starting to think about the governance for patient-reported outcomes across our system. And it will help us identify what are the system-wide needs in terms of clinical content, infrastructure, and technological capabilities that can support PROs. It will help us in understanding what adjustments do we need to make in our current environment to really facilitate an enterprise approach that can allow data to flow to the right people at the right time. And then finally, it will be helpful for us to learn from those that have been implementing PROS for many years and really have some great lessons to share about how to be successful in PROS. So with that, I want to introduce our 3 panelists today. And so our panelists are going to be moving through in somewhat of a chronological order based on their experience implementing PROS in our healthcare system. So we'll start with Dr. Heidi Crane, who's going to share her experiences with implementing PROS in HIV primary care, which she's been working on for over 10 years at Harborview Medical Center. Following that, Dr. Natalia Maranova will share her experiences in headache management PROS, which has launched over 2 years ago at UW Medicine. And then finally, Dr. Amy Cizik will share the experiences in musculoskeletal surgical PROS, which launched as part of the value-based payment contracts in the past year. Pass on.
Could I have a different set of slides? Ideally mine. Thank you for this opportunity. I'm going to talk a little bit about implementing PROs and specifically in HIV care. Oh, yay. That would be me. And I'm going to use it first as an example of why we want to do this. Why would we want to do this, implement PROs in HIV clinical care? And I'm going to use as my example adherence to antiretroviral medication, which for HIV is the driver of many, many of our outcomes. And it's something that we can't easily assess. There's no lab test. If you wait until they've already developed poor outcomes, they've developed a detectable viral load, they've developed resistance, you're detecting your problem by the outcome you're trying to prevent, which is less than ideal. And so that's really the scenario. In the top half of this figure, what you can see is what happens in clinical care when there is no systematic approach to assessing adherence in care, because there's many studies that have shown that the provider ability to assess it directly is less than ideal. And so the bottom half of this figure shows something similar, but in this case, there's a systematic approach to PRO collection. And what you can see is that adherence is assessed as part of the PROs, allowing the system to be aware and therefore providing an opportunity for an intervention, whatever that may be, a referral to pharmacy, a pill box, et cetera, but allowing the clinics to target resources to those most likely to benefit in a way that allows potentially improvement in better HIV outcomes. Further, because you are systematically assessing adherence, you have the opportunity to know if your intervention was of use, and if not, you know that the system is aware and you have the opportunity, again, to target additional interventions and potentially lead to better HIV outcomes versus just continuing unaware. So next I'd like to describe briefly what we do or how we approach our assessment. We use an open source, non-proprietary web-based software application that was actually developed at the University of Washington by Dr. Lober and colleagues. Patients complete the assessment on a touch screen. This has many advantages for us. Not only does it mean that the results are in the provider's hand at the time of the same-day clinic visit, but there's no clinic burden in terms of scoring and getting it there, et cetera. It is a much less burdensome approach than a paper-based assessment. And further, it allows us to be aggressive in skip patterns. So we have a much richer assessment because most patients skip many items, and yet we still maintain a mean completion time of under 12 minutes. It's encrypted. We offered in English, Spanish, and recently we added Amharic as our third most common language. It tracks the time patients take to complete the assessment as well as each instrument and item, because patient burden is incredibly important to us. We are integrating into clinic, and if we disrupt clinic flow, we will not be a welcome participant in clinic in the future. This is what the assessment looks like. It's large, easy to read radio buttons. Patients don't get either a mouse or a keyboard because prior research long before us have demonstrated those are the things that are more difficult for patients, particularly older patients, patients who are less computer savvy. So this allows us to have, across our spectrum of patients, ease of completion. This is an example of what our assessment looks like. Our domains are selected really based on things we think we can use to improve clinical care, clinical outcomes. Patients complete somewhere between 69 and 127 items, depending on how many risk behaviors and poor choices they made last weekend, so to speak. And we found that this has been highly acceptable. So it's easy to use, it's understandable. This is on a 1 to 5 scale among patients in our clinic, with 5 being what we're hoping for and 1 being oh dear. And they may not enjoy it as much as, but it's probably not the funnest thing they will do that day, but they're understanding it and they're overall very satisfied with the assessment, despite the 12-minute burden we're sort of inflicting into their day. So there are so many aspects to integrating PROs that we could talk about, that we could do this as a day-long course, but I picked one aspect in particular because I think it drives success, and that's stakeholder buy-in. One of the things we did that I think was crucial to our overall success was really focused on stakeholder buy-in. Before we had begun implementing the feedback results to providers, while we were still developing the assessment and making sure it was feasible and assessing how long it took, et cetera, we had 500 patients complete that. Of those 500, 62 told us their adherence was horrid by every definition. And so we reviewed the provider documentation from that same day for those 62 patients. And what we found was 27% of the time the provider knew that the adherence was horrid and acknowledged it in some way in their documentation. 40% of the time, HIV providers didn't acknowledge it at all. And again, I just want to remind you, for those not taking care of HIV patients, adherence is a key driver of how well our patients do. And most concerning of all, a third of the time, the provider had assessed adherence with the patient and documented something along the lines of missed no doses, 100% adherence, et cetera. So they had completely blown it a third of the time among these patients with beyond bad adherence. Beyond that, even among those where they successfully identified the poor adherence, approximately a quarter of the time they missed that the patient was moderately or severely depressed, and a quarter of the time there was current ongoing substance use that the provider was unaware of. This was the data that we then took to our clinic leadership at the University of Washington HIV clinic, and was the reason our clinic leadership said, yes, there is a need for PROs in clinical care for patients with HIV. You may consider it part of the vital signs. So it was integrated into our clinic. It was handed down to nurses, MAs, et cetera, as this is something we're doing to help our patients, and it should be considered a priority the same way blood pressure and other normal routine aspects of clinic care are. So we demonstrated a need, and we were able to implement it in our clinic, but does that really mean we had an impact on outcomes among our patients? So the next study I want to present in brief is then what happens. So we looked at 600 patients, the first 600 patients after it was considered part of clinical care at our patient, where the results from the assessment were put in the provider's hand or available to the provider as they walk in the room to see the patient on that same day, and the last 800 patients who took it before provider feedback was started. So this is a before and after around January 2009, which is when we were considered care for our clinic. And we had chart reviewers, again, review provider documentation from that same day for 4 different domains that were included in the PROs, and we were looking for awareness of issues by the provider, so they knew somehow that there was an issue for each of these domains, as well as actions by the provider. So for depression, did they increase the dose of the antidepressant, or refer them to a case manager, or refer them to psych, or in any way take some action? Those were our 2 outcomes of interest. And what you can see here, there's actually a lot going on this slide, but awareness is the top half and actions is the bottom half. And the light blue is before provider feedback and the dark blue is after provider feedback. And what you can see is that there's some are significantly higher and some of them are just higher for all domains. So depression is higher, and this one was actually a surprise because we had always notified providers of patients with suicidal ideation. So even before feedback in the light blue, we had significant notification going on. But despite that, the feedback still had a significant impact in awareness. And then adherence, the impact is pretty small, but the third column is inaccurate adherence. And that's for patients who had very poor adherence. What percentage of the time did the provider document perfect adherence or miss no doses? And so what you can see there is there was a substantial improvement, not quite as large as I would have liked, but still a significant improvement in how often providers were documenting miss no doses or perfect adherence among patients whose adherence was horrid. What overall this study showed was that you can, with PRO implementation and HIV care, you can improve the accuracy of provider assessment of adherence. You can improve their ability to identify hazardous alcohol use. You increase their actions, such as referral to an AA meeting, et cetera, for hazardous alcohol use and for adherence. You increase the identification of moderate to severe depression, and you increase the identification of substance use. What we had no impact on, the last domain, was sexual risk behavior. We didn't budget. It stunk before and it stunk after, highlighting that although we talk about PROs in general, we really need to think about their impact and their usefulness on a domain-by-domain basis. So I've told you a little bit about how we did it. I told you a little bit about the need we saw, and I told you a little bit about the impact. And so I just want to finish up very quickly with a couple of comments about next steps. And so the next steps we took was CNIX. CNIX is an HIV clinical cohort collaboration of 8 HIV sites. So this is the one part of the talk that's not just from the University of Washington, but we took what we learned in the UW HIV clinic and we expanded it out. So 7 of the sites within CNIX now do PROs, again as as part of clinical care. So the patient does it at the same day that they're seeing their provider. The results are in the provider's hand or on the provider's screen, et cetera, at the time that the provider is seeing them. And at this point, we have now had, we've crossed 70,000 of these clinical assessments have been done as part of HIV clinical care visits across the U.S. among not quite 16,000 patients with HIV in 3 languages, and again, still targeting that mean completion time of less than 12 minutes so that clinics don't strangle us. And what you see here is that you can identify a lot of unmet needs. So, and the specifics don't matter because they won't apply to other clinical care settings, but what you can see is a quarter of the time we're finding moderate to severe depression. There's a lot of anxiety. There's a lot of illicit drug use, whether or not you include marijuana in that. I've included it both ways because we have different geographic regions who have different worldviews on this issue. A third of our patients have hazardous alcohol use, but clearly there is a lot of need for potentially for improved or additional interventions for these patients that can be detected with the PROs, and much of this wouldn't be detected otherwise. And I show this slide, even though the focus of this talk is really about PROs for clinical care, I point this out because our whole agenda was about improving clinical care, but the data we develop, we select domains to improve clinical care, but those are also domains that are therefore important for patient outcome research for these patients. And so as a result of the CNIX PROs, this clinical assessment we instituted across clinics, this is an example of the papers that were published or in press in 2016 using this data. Even though research wasn't our primary objective, focusing on important outcomes for patients, important domains for patients, leads to an incredibly rich resource for research. There are way too many people to thank, patients, providers, and staff, particularly at the UW HIV Madison Clinic. All of the very cool technical things that we do would come from Bill Lober and the informatics team. And then we've had much help across CNIX sites in terms of think aloud, qualitative assessments, et cetera, as we expand this work and want to make sure that it's acceptable and useful to our patients.
Are there any clarifying questions?
Hi, Heather Gold, NYU. Hi. Were the provider reports that were you handing them paper, or was it in the electronic health record? Can you tell us?
Yes, yes it was. So, as I mentioned, we now do this across 7 sites, and in the last 3 years, those 7 sites have had 13 different electronic health record iterations, which is just a little mind-boggling in and of itself. Beyond that, the HIV clinics we work with have a different, so we say median provider age, where some of them are a little more facile with the EHR and logging in at the beginning, and others dictate the note at the end and use it as little as possible as a survival mechanism. So we have 3 different approaches to providing the PRO feedback based on the clinic setup, age of provider, overall EHR, and general happiness with EHRs at that site. At the UW, I actually have it on a piece of paper where it prints out automatically when they complete item number whatever or when they log out. So even if they don't finish, the provider gets the results, and it goes on top of the vital signs so that the provider has to move it out of the way. Another clinic has it up on the screen when the provider walks it in. A third clinic we work on does a feedback form, but they have to sign it because they use the review of systems as a way of upcoding their billing. So we're pretty easy to work with depending on which EHR you have this month.
I had a quick question. I love how it's integrated into clinical care. What are the actual real-world usage rates of the screening, or of the patients using it and kind of completing the workflow?
Sure. Are you asking me about refusal rates?
Refusal rates, or just, somebody says, hey, it's too late, we're going to bypass that, and we're just going to get you in the room or something.
Right. So there's 2 different issues there. We have approximately a 1% total refusal rate. Go away, I'm not doing this, no way, and whatever. So that is just and we never approach those patients again. On the other hand, I think the more interesting question is about patient flow. So we are very careful of the impact of adding something to a clinic. So we never ask them to do the PRO if the provider is waiting, and how big an impact that, if the provider's ready for the patient, they go in. And how big an impact that has varied greatly based on the clinic flow of the clinics we work in. So at Madison Clinic, 5 years ago, they redid their structure to a more sort of patient-centric rather than provider-centric flow, et cetera, and the waiting room time decreased dramatically. So every 6 months, we actually give them a clinic appointment time that's 15 minutes before their provider time, so that we don't miss them because of that. Other clinics we work with have still longer time spent in the waiting room, and we just tell them to come for the appointment, and then we do it, and then sometimes we play cards or whatever with them too, because they've got plenty of time before the provider. But how that works really depends a great deal on sort of what your average sitting in the waiting room time is.
So hi guys, so I'm going to switch to headache right now, and so I'm the director of the headache clinic at the University of Washington, and I'll explain what we have been doing. So I don't have any disclosures, and I worked with my team. So the background is that patients and healthcare professionals are, seeking electronic medical records. As you heard, pretty much it's from Secretary Sebelius, it's currently required in the U.S. to have electronic medical data. However, at the same time, there's a lot of concerns about the information we have. And so currently the questions and some considerations is how do we leverage technology to improve patient care, providing remote care to patients, moving from episodic care to continuous care, actionable use of data, and instead of being reactive, we want to actually have not be reactive. So our goal was to develop a patient questionnaire that could be used in clinical care and research. So currently at the University of Washington, we have EPIC. EPIC is not designed for research, as you know, and the data entry is not standardized. There is no check for accuracy. So the question was, can I have something in the clinic that I can use as a clinician and use for research without then having to ask anyone to give me the data? Can I actually use the data myself? Because what we found from EPIC, we would have to then go and ask the computer, the ITHS, or whoever to help us, and now we have data ourselves. So I'll tell you how we did it. So basically, the big consideration in anything you do in the US is patient privacy, HIPAA. So I was looking, okay, since I can't do this in EPIC, is there any system that I could do it in that is HIPAA protected and that is free? Because I went into it without having any resources, and we use REDCap. So if you look up REDCap, it's REDCAP. If you're working at a university setting anywhere in the world, it's available to you for free. Not only that, if you're working with someone who has their data done in REDCap in one institution, they can get collaboration with other institutions. So our flow is that currently there is no REDCap EPIC interconnection. So what do? We do, and I'll explain what we have done. So we have done the questionnaire in REDCap, however, then we copy and paste the data into EPIC. So we have it in both systems, and then we do our research using the REDCap, not the EPIC. But we have now found another, the University of Washington, they have started working on a program called LEAF, where I can then take all the patients that I have in REDCap and find any other things that I have not included in my records from the EPIC, it will pull it into the REDCap. It's pretty cool. The REDCap questionnaire was developed initially by me, couple of my colleagues at the headache clinic, and we initially worked with a programmer. How do we design it? But then we designed it ourselves. It took us hundreds of hours to do that. But the key here was that we were designing it as what we needed as clinicians. The problem with EPIC was that it was designed by computer programmers for clinicians, not the other way around. And then, the key is going to be here. REDCap is now working on having a merger directly into EPIC, which will make it much more user-friendly. But we find that even this is pretty user-friendly. So what is the flow? So basically, if you want to see me at the headache clinic at the University of Washington, any of you who have headaches, you would be contacted by our staff and said, okay, absolutely, but you have to fill out this questionnaire first. It's an online questionnaire, so you're going to be emailed the link to the questionnaire. Once you finish it, then you're going to be scheduled. If for whatever reason you don't speak English, you could come and fill it out with our medical assistant, or if you are in the age group where you don't find computers, friendly from your perspective, or whatever disability you have, you can absolutely come to the clinic and we'll fill it with you, or you can have your family members help you, and so on, etc. And so right now, basically, we're asking about adherence. So anyone who comes to the headache clinic will have this filled out, so it's 100%. We don't see you if you don't have this kind of deal. And then on subsequent visit, that's what we're trying to figure out the flow. That's a trickier flow. So I think what we're doing right now, how we're going to do it, is you have the options filling it out yourself at home before you come, and the link is being emailed to you. Or if for whatever reason you didn't have time, you can just come to the visit and have it done. What we're trying to figure out, and we haven't found, the best time sequence to actually send it to patients who will never come to see us again, to see how they're doing. And so far, all the patients have been very positive. We haven't had much negative impact. So if you say, what does it have? So what kind of questions did we put in the questionnaire? And whoever is interested, I have the questionnaire here, but we ask, what are the goals that are important to you to discuss during the visit? Let's say, understand why I'm having pain, better understand my current diagnosis, discuss headache treatment. I'm worried that I might have tumor. I'm worried about other disease. I would like other treatment, and then it has, what treatments do you prefer? So some patients prefer medications, some prefer supplements, some want Botox, some want biofeedback, some want hypnosis. What are you interested in doing to achieve your goals? And it goes into change medications, exercise, diet, and so on. I think my problem is caused by, are you planning to get pregnant? What is the reason for your visit today? What is the most concerning thing to you about your headaches today? Do you have a specific diagnosis? How many, and so on, etc. So it has 10 different fields. It goes through everything that we need in our clinical note. And so before I see a patient, I already know pretty much what is their diagnosis. It's pretty much for me right now, we say how long does it take me? About 2-3 minutes. I have the note pre-done that I need to then put into Epic that I just clarify with the patient and edit. It allows me to not spend 90 minutes on typing a note, but have the note pre-done. It pipes all the information from the questionnaire, it allows me then to have the conversation with the patient actually about what they want. Most of the patients that I see have been seen by multiple providers before and still don't have their diagnosis. We have actually, thanks to this, found that most of the people that we're seeing have misdiagnosis, even though many of them have had symptoms for 10 to 20 years. And that's what then leads to not having the right treatments and so on. So kind of moving. So again, the providers access the questionnaire, copy it into Epic, edit it as part of their clinical note, and then we also add the diagnosis into it once we see the patient. So this is kind of the example that you have a pre-done note that piped in all the information. So you can see you have a note ready to go with all the details. What we have been doing is we don't have our own app into what most people do right now in clinical care. They will just says, how are you doing today? So what is, do you have a headache today? But we want to put in the data ongoingly, not just what happened today, what has been happening for the last 3 months, last year, 2 years. And so we have not designed our own app, but we have piggybacked into using other people's apps. So we use Migraine Buddy. We tell people, okay, there's many apps. And Migraine Buddy actually is very clever because it will then compile for you all the headache data, and then people can import the data from the Migraine Buddy into the RedCap for us for the follow-up visit. So that way we don't have just what happened to you within the same day, but we have actually what has been going on within the last 3 months or 6 months. So pretty much we encourage our patients to have ongoing data evaluation to know whether they're improving, getting worse, and taking some ownership, again, of the data. This data that you compile in all of these apps can be then included into the medical record, usually shared with the patient with you. The other one that we use is eye headache for people who don't specifically have migraines. This is for any headache type, and patient puts in their information about headache. It will actually come up with a pretty decent job of telling you what headache type you have, how is the weather influencing it, and so on, et cetera. So people really like this a lot, and again, if they can incorporate then the data into our REDCap that we put. So currently, if you say how many actual individual patients we have had within the last years, so we have over 3,000 patients as we speak. And so these are real patients. This is not something that is fictitious. This is edited data that is actually designed for clinical care and research both. It is standardized. We all in the clinic, have the same data. It is checked for accuracy. So if there's something incorrect that you filled out, we actually correct it. And so this is kind of where we have moving. So now we're starting to have posters out of it, and we have now identified things that were not known before, such as that sleep is a very big impact. 70% of people who actually have problems with headaches have also problems with sleep. So we started doing a sleep shared visit in the headache and collaborating with our sleep experts. We also found, let's say, that anxiety and depression are very significant contributors towards chronic headache. So how we're starting to model it is, instead of going like, oh, you have headache, we're going now, we have, yes, you have headache, and you have anxiety, and you have sleep problems, and you have increased BMI. So we're starting to model it across multimodal, and we see that in clinical care, you actually need to address all of these to improve your headache. So, very significant, again, depression and stress. And so I can tell you any of the data, like what patients are taking before they come to see us, what was their diagnosis, what medications they're taking. We have the information on marijuana, and so on, et cetera. We're going to be moving further into doing those publications. So kind of the summary. So patients, again, fill out a questionnaire before they're seen, before they come for a medical visit, which leads us to have the time to address the questions that actually they want. Because we ask the patients about their preferences, we actually do kind of shared medical decision-making during the visit. And so if you come to me and say, I hate medications, I'm not going to go like, oh yeah, let's put you on medication. I'm going to say, okay, let's discuss what is the issue with medication, and do you really, is that a no, or is that a possibility, and what are the other options, or we can start with other options first. And so this kind of questions. So.
Are there any clarifying questions?
I think the obvious one so far is, how about the HIV patient with headache? Is there any crosstalk?
So, so you might want to even clarify your question further. What do you mean by crosstalk? Or, if Heidi wants to. Yeah. Right. Yeah. Yes. Right. So they don't feed into each other, and that's why we had actually, we so much appreciate Elizabeth and the whole team, because she started looking across the system, right? How do people, use these different systems, and starting to think of how do we then cross-talk, or is it even possibility or not? Because we don't want you to fill out a depression questionnaire in the HIV clinic, in the headache clinic, and at your primary care. We want to be able to move towards having one platform where anyone can assess the data, not only have the interpretation of data, because the problem is there's so much data, right? And data overload, I would say. If you go to a primary care physician, how do they even choose or decide what is important and not important? Like, let's say we have all these scores of anxiety and depression, but most people are not trained, let's say, on suicide prevention, and so on, et cetera. So it's like you get the data into the system, but who is then notified? Who's going to act on it? How do we act on it? And how do we not put the burden, on having, as you said, having you fill out the same data over and over, and I think that that's the continuity of care. No one has now the apps within the Epic, where you input the data every day. Even if you did, who would then screen to make sure that it's something actionable or not? And so this is really good questions that we're, hopefully going to be starting to assess. Because it's, the other, problem is if something happens to you, and I have 6 states that I observe, so if something is happening to my patient in Alaska, or Montana, so how do we then act on it, And so what we're trying to work is much more, I'm a super specialist guy of like the tertiary or quaternary center, working more closely with primary care physicians as are, the main people who are impaneled, who have smaller panels of patients where they can actually work with us, learn from us, and we work and we learn from them. I think that's what is really needed, is more, as you said, collaboration of all the fields across the medicine.
It's really very different. I mean, they're both really interesting,
Yeah.
but they're very different models, right? So the one model is incredibly fascinating. It's incredibly in depth, and it's done before you could ever get an appointment. So it's sort of, and it's incredibly in depth in a way that I would never be able to do in an HIV clinic where a third of my patients are homeless and Amharic and, et cetera, where I'm trying to collect the info. I don't assume my patients have a smartphone. I don't assume my patients have laptop access, et cetera. So I think there are several huge differences. One of them is the primary care versus sort of subspecialty, tertiary care sort of thing. And the other is the patient population we take care of. So I'm at, as was mentioned, the University of Washington has multiple hospitals. I'm at sort of the county hospital where the homeless go and the underserved, et cetera, et cetera. It's a very different population. And I have no expectation that if my patient's having headaches, that I could refer them over and have them successfully navigate to a different hospital, et cetera. So we actually bring a neurologist into our clinic who sees our patients, because I have no hope that, we bring a neurologist in, a dermatologist, et cetera, because the populations we are each serving both have really key needs, but they're incredibly different.
And we do see patients from the HIV, clinic, but as you said, then it gets to, then going into our systems. I mean, it's a very good point. I mean, this is a point of why do, not only us within one center, but why is US, we had a discussion of interoperable medical record. It's a fiction, it doesn't exist, right? But, it's a nice, future to, move towards and have the goal to move there. Currently it doesn't. And the other piece that is very interesting to me, so most people, when I started doing that, like the response of most people, I don't know, how many of you guys are clinicians here? Is there any? No, so a fair number of clinicians. And so how many of you have been thinking that your patients could actually pre-do all the information before they see you, and in a way where you could actually use it as a note, so you wouldn't have to then, retype it or put it from a piece of paper. And I think that was my goal as a clinician. But the other goal was we're seeing real patients, yet all the studies are on 20 or 30 patients in headache or 50 patients. I have now 3,000 patients. They're real patients. Yes, it's going to have bias of this is a tertiary headache clinic, these are the people who didn't, and so on, et cetera. But that's what people are looking for. How do I treat the resistant patients that no one has succeeded with? And we have that.
We'll take
Okay,
one more
one more question. Yeah.
Hopefully quick question.
Yeah.
Roman Shuki from Yale.
Okay.
One clarifying point
Yeah.
that I had was,
Yeah.
do you have any sense of your non-responders and kind of what that population looks like? I think we've been thinking a lot about these
Right.
years and coming across the whole issue of the digital divide in terms of who has access to internet at home and these sorts of things. So I was curious if you had any data on that. And then the other question I have is I was so impressed with the nice prose paragraph that kind of takes your survey data and makes it into a note. And I was just curious, technically, is RedCap
Right.
able to generate
Yes,
that
yes,
paragraph?
yes. Not paragraph, it's actually 3 pages, but I just showed you a piece of it. So you can, RedCap can pipe any information that you want, so it takes it from the individual fields into your kind of pre-type, like patient came with, chief complaint of, seen by, I can show it to you later. The question is, you said about compliance, so we have 100% compliance because of, you have to do this in order to be seen, so.
I understand, like the folks that are calling in
Right.
for an appointment,
Right.
being told to fill out this survey, but then perhaps not calling back or not recontacting your clinic.
We don't, so.
Barrier there.
No, we're not collecting the data, and that's a very good question, So, how many people then, are screened out? But as I said, if you can fill it out, then you have a medical assistant, that can do that. Or the other form is people can do it, again, prior to the visit, but it's done on all the patients. That's basically something we do. Now, the second piece is we have an IRB to use the data, and if you decide not to use the data, then we just delete it out of the system. So we do that as well, yeah. Thanks.
Heather, I might be able to answer your question too a little bit. Okay, so where do I want to start? First, I want to acknowledge one of our collaborators who is not here, Danielle Lavalley. She is actually leading this endeavor across our system in terms of integrating this system-wide. And I'm actually giving this side of the talk on behalf of her, but also because I sit in orthopedics. So we're going to talk about integrating PROS into the musculoskeletal surgical care space. And I debated whether to put the surgical because we really had to think about this on a few levels and back to not wanting to over-duplicate things. And many patients, and you'll see we'll get into lumbar spine, start in a pathway in various clinics, whether it's primary care or physical med and rehab or in the pain clinic. And so we have thought about this from kind of two approaches. And it was interesting, I was at the Promise Health organization before coming here. And one of the institutions talked about their system-wide EHR integration and how they've designed their system, and it's fantastic. And then kind of the summary statement was, and now we're going to work on governance of this system. And I would say our system has had a very different approach to that. So we have really thought about the governance piece from the start and how this is really going to be structured and used across the system. But then allowing individual clinics who are doing these other things not to stifle that, to encourage that, but how can we kind of have core measures across the system that everyone's getting in a specific manner, and then allowing people to build on top of that. So two things, there's the system level for population health needs, and then we're going to talk briefly about kind of what's going on locally or in the individual. So Elizabeth showed this earlier, and I edited this slide down to just show you this is where all the musculoskeletal patients interact with our system. They're in the neighborhood clinics. They're at Harborview. We have orthopedics and neurosurgery spine clinics that sit not only at our one hospital and serve a different community, as well as at our university hospital. We have pain clinics. We have sports medicine clinics that these patients can actually come through. And then we also have orthopedic hospital. Our hip and knee arthroplasty services sit within our Northwest Hospital. So all of these touch our musculoskeletal care patients, and so we need to think about when we're doing patient-reported outcomes, how is this going to integrate across all these hospitals and all these systems? Really, in musculoskeletal care, the decision-making has occurred from a contractual level. So this is what started this process really across our enterprise, is that in total joints and lumbar fusion, we are seeing more and more of the bundled care and value-based care requirements. And so we have contracts that are requiring patient-reported outcomes as part of our contract. And so you can see here from the federal and the CMS level, we have requirements for the total joint replacement. And I also want to draw your attention as I go through these, all the various requirements. So some of them are actually measurement specific, whether it's the HOOS and KOOS or the Promise instrument. And sometimes it's just a requirement of a specific domain. You need to be measuring physical health or depression or anxiety. So not only do we have to use specific measurements, but then we also have to see if those measurements include the required domains for some of these other conditions that these patients may also have. And so that's why I put the annual wellness visit in this slide as well, because that is also required. And boy, this is kind of hard to see here. So you can see where we might have on the Promise Global Health, which is an overall quality of life measure, we may not be getting some of the fatigue measurement, or we may not be getting the self-efficacy emotional problems that are required in an annual visit. So how do we integrate this? And then we also have in Washington State, we have our healthcare authority that has made some recommendations as well, especially in the area of lumbar spine. So there we have a condition-specific instrument that we're required to use, the ODI, as well as the Promise 10. So there is some overlap, but there's also some domain specificity. And then at our system level, many of these have been informed by the prior regulatory bodies. But I wanted to touch on the depression. The BHQ-9 has been used in our depression clinics, and they have their own requirements for various registries or various reportings that they do. And it's also been well integrated into the pain clinic in terms of screening and used as a clinical tool. And many of the lumbar patients start sometimes in these clinics. So again, we have to think about, while the Promise 10 may ask pain questions, we have requirements on the BHQ-9 from a clinical. And then the addiction screening as well. So what's happened on the local level in terms of the clinic-specific or the condition-specific requirements? So for lumbar spine, and we just got started, Elizabeth can touch on this a little bit more, but it's been within the last year, and this has been a very integrative process, and we've only started this in our HMC spine clinic as a rollout. And you can see here too, I want to draw your attention to the time points too. So not only do we have domain specificity measurement specifications, but we also have time points that were required. And these time points don't all necessarily overlap across the different conditions. So you'll see in the next slide for joints that this time frame looks very different. This is the path or the flow that we've established. A clinic RN basically releases an order set for these pros. The patient sees it. They can complete it in MyChart prior to their clinical visit. We only have about 30% of our patients actually enroll in MyChart. And then of those, that number I'm not as sure, but I know it's less. Of those, there's a small percentage that actually complete the Pro Series. So then what's really happening is they come to clinic and it's being done on paper during the clinic visit. And one challenge we've also had is just the integration of the IT systems, having iPads in the clinic and who manages those iPads and who's in charge of those iPads. And our IT systems are overburdened as it is, and this is another piece of equipment that we don't want to manage and maintain. So right now, it's being done on paper and then scanned into the Epic system currently. And then the patient completes the pro's in Epic, and then we have to figure out the reporting side. So there's not only all this integration into the system, but then getting the data back out and getting it to these regulatory bodies who now are requiring this information. The other challenge in lumbar spine that we have had is this idea of definition. So for the regulatory requirements, this is only being required in a single level lumbar fusion. Well, that definitions become challenging. What is a single level? Is it, the vertebrae above, the disc, and the vertebrae below? Is it adjacent? So we've even just been working on the definition of the population that these requirements need to be reported on. But then again, while we're requiring this pathway for that specific condition, we need to be thinking about this broadly across all patients that come in with a lumbar spine fusion. And so how does that change how we implement this process? So I'll move into joints. We've had a little longer time frame in that. We also have a very site-specific area in terms of our hip and knee, a little more robust integration there. And we've had a great champion in one of our colleagues as well, Naomi Maxley, who's just done a fantastic job really thinking about this program. But here you can see it's kind of a similar, but again, the reporting out to CMS and not only getting the data in, but getting the data out are things we've had to think of at the local level in terms of reporting these. So here's just some draft of what's happened in our clinic in terms of pros orders, or actually ordered, those that have actually been completed, and which domains or measurements in terms of the HOOS and the PROMIS. And you can kind of see over time we've slowly ticked up in terms of completions. And a lot of that's been whenever we have run into problems or seen problems, we're at the clinic level, talking to the clinic staff, talking to the clinic managers, how can we integrate this better into the clinic workflow? In joints too, I know we've struggled with the issue of laterality. Some patients, they come in for a left knee, they get that knee completed, and now they're having pain and trouble in their right knee. And if we do an assessment, is that a baseline for the second knee, or is that a follow-up for the first knee? So we've had to work through those decision rules as well. So next steps in the musculoskeletal care, and I think to really answer your question, Heather, it's come up in our governance meetings, we do need to pick a core measure and a core set. And we had an initial poll here just last month of, what did the group in the terms of the governance really think was a core measurement or domain level? And I think everybody seems to agree function is an issue, pain. Then you kind of start to go, depression, maybe we should measure fatigue. So everybody wants their piece measured, and that's understandable. But really, what are we as a system going to prioritize? And I know Janelle's in the background, and she's dealt with this issue, and we've had conversations about this as well, and just what is going to be required of everyone, and then what's going to happen within each individual clinic. We're still expanding our rollout of the lumbar spine and working to improve that process. And where does the annual wellness visit fit into all of these subspecialty clinics, and how does that get done? Implementation is something we're very aware of and working on with other people. You know, we do want to reduce the burden, and the real world experience is something we are very cognizant of. And I think back to the real world issue, something I'm struggling with as a PhD that sits in a very clinical department, you know, that we are wanting to do this to inform clinical practice. And this is not driven by a research question, and this is not research, this is for clinic. But you can see the benefit too is we do this clinically, we can get some research out of it on the back end. And so I think one struggle I have is convincing our orthopedic providers, you know, kind of if you build it, they will come, is look, we need to get this system in place, we need to do this, and then we can get data and you can get your research papers, but let's think about this clinically first. And so kind of that culture change. And I think the hope is that eventually we'll have enough data that we can do more shared decision making, especially around these issues of elective surgeries where there is a lot of uncertainty. That's all I have.
Thank you. So I wanted to get discussion started for the panel overall by asking each of the panelists to share some thoughts based on their experiences in their individual implementations in specific clinical areas. What recommendations would you have for health systems who are starting to think about PROS more broadly? So I think maybe we'll start off with Heidi.
Okay, great questions. What do I think the systems that are thinking about PROs more broadly should consider? So the things we have done that I thought were incredibly valuable included we skipped the whole do it on paper, et cetera. We went straight to electronic, and I think that was incredibly useful because it got rid of all the crankiness from the RNs, et cetera, who had to do the scoring and then the data entry, et cetera. And I think the fact that half of the staff didn't hate us from day one is a good start. The second thing, just in terms of thinking about more systematically, I think the fact that we don't assume that all of our patients have sort of have a smartphone, have access, et cetera. And at least in HIV, we work so hard to get our patients to come back. We have this huge loss to follow-up rate and people flake off, et cetera, and we don't want to encourage that. So one of the things I really like, and I think should be considered even for populations that might be a little less socially, shall we say, dynamic than ours, is that we started with an in-clinic-based assessment. Now, one of our clinics also has it through a portal, et cetera, so if they do it at home, that's great, but we never make assumptions that they can do it at home. We sort of always go to sort of the broadest approach, the least common denominator, let's be as inclusive and welcoming as possible, and then we do things like add the patient portal at one of the clinics in Boston, et cetera. We add that stuff on because that reduces clinic burden and reduces flow. So I think that is the other sort of take-home I really like, because I think being very, very inclusive and then making things easier is a nice way to not throw out the people who are at greatest risk and the ones we want most to get their substance use and risk behavior info on.
Thank you.
So, I agree, but Heidi, a couple of thoughts that I had was, don't just wait, until everything is perfect. I think that can start with something maybe in a smaller scale, and then learn from mistake, look at other, organization. I mean, you can learn from other people's mistakes, and see what other people, are doing. And then I think it's really key to have who's going to be key person to start the change management, because that's a lot of what you're asking is, it's going to be easier when the people are coming in, but it's more difficult for the people who are already used to doing, something in a standardized way. So kind of thinking through, anything that you want to succeed with, you have to have the buy-in. And so how you do the buy-in so people are excited and don't feel, it's yet another burden, as, Heidi said. I think that people are willing to contribute, patients much more than you would believe. So I think that she said there is vulnerable populations, but a lot of, even in a lot of the homeless populations, and again, I'm not saying, people do have, smartphones and so on. So we've had a number of homeless people that we have, seen who do have, their things filled out, whether they got it through the library or friends, and, but, taking into consideration, there's many, many factors that are going to it. The biggest factor for us is going to be institution-wide, it's exactly, there was an excellent question, like how do you not duplicate, things, and where do you have it in an easy way to look, open the Epic, let's say, and, find immediately all the data before you see someone, before you see the patient. So it's not just wasted work, that people are doing, but it's actually something that's done with the data.
I think what's really struck me is this idea of kind of the governance issue and really setting up a group across the hospital with diverse backgrounds that are contributing to the discussion, because you can see, orthopedics hadn't really started anything, so it was influenced more from the administrative down in terms of contractual requirements, but you can see other clinics have done their other things, and you don't want to quell something that's been good and working well, but then you also have to think of the bigger picture too. And so I think setting up a governance structure, and Janelle, I'd love for you to weigh in on this if you wouldn't mind, because I know, appointing a director, appointing somebody who really is the leader for this, and then is helping establish change, I think at the administrative level. And one thing we're going to be doing next is engaging the department chairs. And I know in orthopedics, that's going to be key to getting the providers on board for this, is really the chairman saying, you must do this, because I think it will be challenging otherwise. So another issue is bringing clinicians who are doing this and are in the trenches to the table.
Yes, I'll just give an overview. I'll just give an overview of where things are here in Pittsburgh. So I'm the new medical director for patient-reported outcomes of the UPMC system, which is 38 hospitals and 600 clinics. I'm greatly indebted to my predecessor in this position, who is Rachel Castell, who comes to this meeting, and she did a lot of work about 8 years ago to figure out how to get patient-reported outcomes routinely collected in clinics, and we use Epic as our outpatient thing, and so we could fill it out online before coming in, or you got a tablet when you came in, if you didn't fill it on the tablet, and the medical assistant would help you complete it. For engaged clinics, we get 80% completion rates. For unengaged clinics, we get more like 30 or 40. And by engaged, I entirely mean provider engagement. That is all that really matters in getting this done. Rachel left a few years ago. It's basically been turned into an administrative position in which clinics would come, they would do one-off builds and sort of build this for headache, and this for orthopedics, and this for ENT, and this for gen med, and all of these things. And so when that person left and I came in, it was great because the vice president of quality for the entire system said, I believe in these are really good, all I have is noise, right? Like, she's sitting way up here trying to compare physical therapy to orthopedics to rehab to PMR to she can't. And she gets it, and she has the power to say, I want it. And so she's the lead of the effort, and we're going to try to get a core set of measures across the PMC every patient every time. That's the goal. And so you don't get lots of follow-up problems, right? So you can actually, even if they never come back to ENT clinic, at least we have some of the same measures going forward. But from my perspective, the main thing has really been that very high level of leadership, someone who has to make decisions with the data at the end of the day. And she gets it. And she's a huge patient advocate as well. So I was in a meeting, sorry, I was over for you guys.
That's okay. I know.
I was in a meeting, and we sort of had a universal set of generic measures that we want to have across the system. And they collect the goose and cross-10 and all that, because we're in the bundled payment system as well. And the orthopedic folks there said, I think this is a waste of my patient's time, this doesn't matter to them. And she turned to them and she said, which of these don't matter for your patients? And they all lost their color and shot. And that's the kind of
That's awesome.
But I do think that there is, I mean, you know, it's one of these, like, we're all sort of, we've been hanging out a lot lately. We were in Chicago for the promise measure, and it was amazing to watch everybody struggling with the same thing. And a lot of it does have to be local solutions to your local technology and the rest of it. And it's unfortunate that Epic no longer allows you to share code, for instance. But I do think that there is a huge group of people actually out there who are all kind of trying to figure out how to get this done all at the same time. And, you know, we're all really nice, keep talking to each other because it's easier when you have friends.
That was great, by the way. But I like, in terms of thinking through, so I can't reinforce enough what you just said about stakeholder buy-in. Like, by presenting data, I think, to our providers that said, this will help you take better care of our patients, I think how unpleasant this experience was for us was just many-fold different. So our providers got it, that you show them data that says, you're missing 2/3 of the adherence, et cetera, whatever it is. And I'm not smart enough to know what the domain of interest should be for ortho or whatever, but that's, in my opinion, how you not have the crankiness factor. And my life is all about less crankiness. The other point I wanted to link about, the sharing code with Epic, et cetera, I think one other take-home I think we've had is the EHR, like, the world of EHRs is in such, oh my God, flux right now. It's just a train wreck, and that even when or at least, a system has one, a few years later, it's either a different version or a different system, et cetera. It's just this moving target, and that's not just at the UW. It's all of the clinics we work with, at multiple sites across the U.S. And so I think the other thing, at least that our clinic did, that allowed us to survive and then expand to many other clinics is we used a standalone platform, and we feed our PHQ-9 goes into Epic. We feed into, let's see, Fenway has a centricity, and the results feed into it's called a worksheet for them, et cetera. So we work with various EHRs, but we don't require, count on, or utilize the EHR. We have a standalone, and so as each clinic has a different EHR, it's a different month, so they have a different EHR and a different IT director. We don't keep getting thrown out or keep getting toasted by this sort of ever-evolving. It doesn't seem like, and maybe I just have a sort of twisty, warped worldview, or maybe HIV clinics are horribly unstable in their EHRs. It doesn't seem like EHRs today are sort of stable enough to try and institute system-wide approaches because they keep changing. And so the more we can sort of do standalone that feed in, like Epic has these new apps, Start on Fire, et cetera, that lets us feed data in much easier than a year ago, et cetera. I mean, the world is getting much, much easier, but sort of trying to stand back and stay out of that fray as much as possible, at least for the next few years until there's a grip in the EHR world, I think is probably worth considering.
Thanks. Yeah. In the Netherlands, there's also a lot of interest in PORs, but there people are also talking a lot about the possibility to compare PROs between providers, which I think is, and then to improve quality of care based on that, which I think is difficult. But so I was, surprised/happy to hear that that seems not to be really the direction here in the US. You are all talking more about internal use and internal quality improvement. So can you comment on that? Are there any attempts here to compare between hospitals or between providers?
I could comment on that from the sense of promise. I think that is the promise of promise, and I have a bias there, so I'll just disclose that bias. I'm a big fan of promise. That we have a domain-level measurement system that a physical function in this population is the same score as a physical function in this population and standardized to a general population mean. And I think moving in those directions, and especially sitting in orthopedics that is very legacy measure based, and the hip has this and the knee has this and the hand has this, it does make it very difficult to compare it. So I think moving into more generic health measures and really domain specificity, because then we can intervene on it. Right? Yeah. If we have these and the Promise 10, and I've had lots of discussions about this, I think it's very hard to do anything meaningful with the Promise 10. There's 2 items per domain, and how as a clinician, if we are using these in clinical practice, can you then intervene on what it is? So if we're measuring physical function, then we know, okay, we need to work on physical function. Do we need to send this person to rehab? If we're measuring depression, okay, we need to send this person to somebody who can help them with their depression. So I think there's much more clinical relevance at a domain level.
Yeah, but I also meant, say, hospital A and B, and I have a mean score on quality of life of X, and the other, so in the same patient population, but if you have a higher score, then, that could mean something in terms of your quality. That's the direction that's really going in the Netherlands, where I have my hesitation, actually.
Yes, so we have scores on various domains across 7 HIV clinics, but we're not really using them to sort of judge or critique clinics. We use them, the agenda is all about improving HIV care. So the fact that Hopkins has way more, crack use than we do, and I get a little bit of grief because apparently in Seattle we're very depressed and we use a lot of crystal, and et cetera. I mean, we definitely have differences across our clinics, but we don't have as an agenda using across our HIV. I'm just speaking HIV. I don't know anything about the real world. About in HIV though, we don't have a trying to impact providers, et cetera. We do a lot of trying to impact resources in a clinic, and maybe we need more support for substance use in this clinic, and maybe we need that. But it's not about sort of critiquing providers, which I think is what you're getting at. It's really about, the whole agenda is improving clinical care. So it's, can we target patients who would be more likely to benefit from intervention X? Can we improve the resources we provide in clinic B to allow better substance adherence, alcohol, crystal,
I think
whatever?
your concern is valid, though. It has come up. And it's even come up in Washington State because we have a big spine collaborative, and I think it is a concern I have that it's not used punitively. So I agree with you, and I think really focusing that it's to improve outcome and patient quality care.
I think that your point, is really well taken, and I think that someone mentioned before that 80%, of whatever the health is, other than non-health factors. So, it's not the provider patient, it's, all the other things. And that's what we're finding, let's say in the headache clinic, it's, it's not only the education level, but it's lifestyle, how much you exercise, how much, you sleep, what is your nutrition, what is your self-care. And, again, we're not, trying to be punitive, it's just trying to, understand and see, okay, these are kind of how I word it, is opportunities. These are the opportunities, that we have to, see, because I think that currently with a lot of the, here, saying like, oh, if he does this and doesn't work, and I can tell you, one of the comments that Secretary Sabella's when she said like, oh, if they don't have good outcome, we're not going to pay them. Well, but good patient, good outcome, and so that's what no one is talking about. If someone is skinny, and is exercising and has good nutrition and is going to have a knee surgery, they're going to have, better outcome than someone who's, sad and depressed and not moving and, has crappy lifestyle and so on. And, I think that those factors currently are not taking into consideration, at all. The bigger piece in US, I don't know how it is, for you, but is non-compliance of patients. So we now know, we don't know it in our clinic, but we know across US that it's less than 50% of people who will actually go, and do what you say after the visit. Within a year, it's less than 30%. So the long-term chronic disease management where it's, basically the biggest issue is not getting people, let's say, to quit alcohol, but not relapse. It's not to fix the hypertension today, but actually continue taking the medications 2 years from now, but not only the medications, but actually staying with the exercise, staying with the, nutrition plans, and, if you say this is all opportunities for all of us, is saying, how do we then, outside of the healthcare right now, it's all on providers, you need to have many, many more people within the system, involved in that ongoing patient motivation and ongoing, move towards, like France had, improving nutrition for the country and so on, that we haven't done. So it's complicated, but we appreciate your point.
So I just want to think about the patient as a stakeholder in this. And so So the reflection is that we've been on a Tom's project with a patient partner who challenged us and said, what's in it for patients? And you can say, well, it's going to contribute to better care, and positive data together will help us to know better, and etc. Maybe in the clinical, it will help the physician sort of make judgments. But I think they're basically saying we'll do it if the doctor kind of tells us to at the clinic, but if you want us to follow up and do it online in the future, then I'm not totally convinced. So I was wondering, firstly, have you included patients as stakeholders in the design? Of the
Yes,
system?
yes.
And
Oh,
secondly,
very good.
have you considered what's the incentive for that
Right.
individual patient right there at that point to be doing it?
So a couple of things. So yes, when we started designing it, we actually worked with patients, on designing all the, how do you ask that question to get this response? Are we wording it well enough? Is this too long? Can you do this or not? And continuing tweaking it, based, on the patient input. But you say, what does patient get in the US from it is, if you come to see me right now and you didn't have a questionnaire, I have to spend 30 minutes entering all your data into the computer that is required from me. If you do that, then you have that extra 30 minutes, to discuss actually what you want to discuss. So this is a very big motivation for majority of the people. Will say, thank you for asking this. You clearly put a lot of thought into it. Clearly, and for them to think about what they're going to be asked, before they come to the appointment. So most of the people we had actually, that was the main concern that we initially had, when I was director of the clinic, with other, providers, right? Is it was the conversation, okay, we're going to start rolling it. And initially, some people had exactly the question you had, like what do the patients get out of it? And they're not going to be compliant and not do this. And now that everybody's doing it, and people feel very, very happy with the appointments. They say, wow, your providers are awesome. They spend time with me. This is the first time in my life that actually a physician stopped and wasn't using the computer the whole time, actually, looked me face to face, spent an hour, with me addressing my issues. I mean, you would have to see, we get that patient, and I have tons of videos where patient after patient after patient will tell you that. Like someone actually spent time to listen to me instead of
This is
just
part of a
typing the notes.
PCORIA word, and Elizabeth, I'd love for you to comment on what's being done on that side of it from kind of the integration piece.
Yeah, this work is funded by both ARC and we have another project looking at patient-generated health data that's funded by PCORI. So both of those projects involve engaging a variety of stakeholders, including patients, interviewing them to understand what their preferences and values are for using this data in clinical practice, and then supporting a framework for how we can determine which types of PRO measures or which type of patient-generated health data make the most sense to integrate into care to support clinical decision-making. So that is part of this.
Does it answer your question?
Yeah, I think it's that was good. So I think just no response, but just thinking out beyond the clinic, so the follow-up, I think it's a bit different, and that's when it calms down in-house, and that's a sort of slightly different challenge. That's where worldwide you see actually the response rate is pretty poor in general.
I think the other piece of it is the main thing that is really, really important, if you have someone on follow-up actually pull the data like we have, the ongoing app that people use every day, to monitor you have to act on it. You have to actually look at the data, discuss it, but not just have them do something without you, seeing why you're using it, right? Does it change your medication? Why are you doing it exactly? As you said, it's really important to tell the patient that's what we have on the record, why you're filling this out. Absolutely.
I was just going to follow up on something Elizabeth said. So we have patient engagement, patient stakeholders, et cetera, patient panel, et cetera. I think the two most interesting things from our patient work that we did that I just loved was, one, we put together a patient panel of the crankiest patients in my clinic who always said no to the PROs and made them my little patient panel, and we paid them, and they came and talked to me once a quarter about what we were doing, et cetera, and what parts they hated and why. And I didn't, for many patient panels, I sort of select people who I think are articulate or represent my clinic well, sort of someone who's an MSM and someone who's an immigrant, various groups. And for this one, we selected the snarkiest, crankiest, get that tablet away from me group in my clinic. And it was really effective. So that was the one thing I thought that worked really well. And then the other thing I thought that was really interesting is we do domain priority work. We do a lot of thinking about what should we be asking, because we're so very targeted in terms of our time burden, because we don't realistically think we will ever get a large group of our assessments done outside of clinic. We are never going to be the group that has 80% at home unless we start throwing out all of the patients we really want to capture, and it's just who our patient panel is. So, we have a horrible sign-up rate for MyChart, et cetera. We are just not those people, and that is what it is. So we are very targeted on being very short and implementable in clinical care, et cetera. And we were interested in sort of various stakeholder priorities for PRO domains. And we did the providers. What did the providers think was most important? What did the patients think? What did, patients who were newly diagnosed with HIV, where stigma and other things may be more of an issue versus those who'd had it a long time, sort of all of the sort of relevant patient groups. And the thing I found that I thought was so incredibly interesting was how very different what a patient says you should be asking in terms of PROs to improve clinical care, not just for them, but for patients with HIV, versus what a provider does. So my patients think they don't really need to tell me about their crystal last weekend and the fact that they had 10 sexual partners, et cetera. And I still do. But if you look through, they totally, there's patient buy-in totally about how important it is that we're asking about adherence. There's patient buy-in totally about how important we're asking about symptoms. Whether or not they think stigma is important depends very much on sort of which sort of demographic clinical patient group it is. But versus the providers, which look very similar all the way down the line. So it's almost a really fascinating area to sort of delve into and think about in and of itself. What drives sort of patient priorities and preferences, and some of them aren't quite what I want them to use to drive their choices. I really do want to know about your crystal use and your 10 partners without a condom last weekend. As a provider, I just do. So there's, I think, some really interesting things there about sort of what it means when they prioritize. But I can't advocate enough for the cranky patient panel in terms of the way to get useful info.
So I want to recognize that we're at time.
sorry.
So no, you're totally fine. I think maybe we'll take one more question, and then we're happy to answer questions up here after as well. So go ahead.
So my name is Bob Rozenbeek. I'm a stroke neurologist in the Netherlands, and we just started with implementing PROs in our region for the acute stroke care chain. And we also are experimenting with a contract with a healthcare insurer in our region for a value-based purchasing contract. And I was wondering, the last speaker told us about that the PROs in the orthopedic example are especially collected because of contracting reasons. So what these PROs, what the role in these contracts is for these PROs? Can you comment on that maybe?
That's a good question, because I have the same question of the people who are requiring this of us. I think it's really to demonstrate in orthopedic care, right? A lot of elective surgery, the indications we could argue are maybe not evidence-based, or so I think they're looking at it more as a documentation to get some of this data to decide, are we really improving care? Do these patients have outcomes, and do we want to cover this in the future? I think that's what it is. That is purely my speculation. One question I have back to the contractors in terms of measurement selection, it was one of these, this is the most popular, I think this is what we should do, but I don't know in terms of thoughtfulness, in terms of why these measures were, and one question I have is, can we go back to them and say, what is it you really want? Why are you requiring this? And are we measuring what you think we're measuring? So if it really is, did the patient improve physical function? Well, then let's just measure physical function. So I don't think that really answers your question well, and it's something I want to know more about, and I have questions around too. Okay,
thanks.
The one take home, I think, from the sort of requirement issues that, at least that we've seen with HIV, is because they're so different. There's one insurance group in Massachusetts that requires depression more often than we do. We do it every 6 months, and they want it whatever. And so it actually highlighted again for me the huge advantage of sort of having this facile outside the EHR platform, because I just programmed it. If this group of patients are coming into the Fenway Clinic in Boston, they get the PHQ-9 every time they do the PROs, while we would typically do it every 6 months. Or, we have a bunch of skip patterns built in for measures that change very slowly. They only get it once a year. Other measures they get every 6 months, et cetera, just to minimize patient burden. But because we're not sort of EHR driven, we have a platform that it's very easy for me to just sort of click anybody who's in this group. I want to change the skip pattern for this instrument, which doesn't make the fact that it's required for this insurance versus that a more reasonable life choice. But it does mean that it doesn't make my life suck, and that it gives me a lot of sort of clinics really like it because I make their life easier. And the more of that you can do, even if your agenda is clinical care, the more you make their life easier, the less likely they are to, be annoyed at you later.
So I want to thank our 3 panelists for sharing today, and thanks to all of you for joining. And if there are any other questions, you're welcome to come up, and we'd be happy to talk about them after.
Thank you.